It is my honor this morning to introduce our Grand Round speaker, Dr. Ushma Patel. Dr. Patel completed her medical school at Loyola and then came to UW for her residency and her fellowship. She is currently the third year Urogynecology and Reconstructive Pelvic Surgery Fellow in our program. Dr. Patel's track record has been exemplary. She has a very strong scholarly activity track record, including 6 peer-reviewed publications in the last 4 years. She was the lead author in the study Updated Prevalence of Urinary Incontinence in Women, 2015 to 2018, National Population-Based Survey Data. That publication not only earned her a 2022 Media Impact Award from the journal, but in 2024 was Urogynecology's top cited article. She has a, yes, exactly, applause, it's awesome. She has a strong interest in both urinary and fecal incontinence, and her fellowship thesis project is in fecal incontinence. She's here today to share her expertise and to educate us all in fecal incontinence. She is excited for next year, can I share? Joining the Medical College of Wisconsin, so we get to keep her as a close relative in our program. So with that, yes. Thank you. Dr. Patel, please join me on stage. Thank you, everyone.
Is that what? The big reveal, yeah. I was waiting for my grand rounds to. Okay, so thank you to the department for the opportunity to give this talk. I have no relevant financial relationships to disclose. My objectives for this talk are to define fecal incontinence by terminology and classification, identify relevant pelvic anatomy, describe components of a focused physical exam for fecal incontinence, list validated bowel surveys to quantify and categorize fecal incontinence, and finally, to recommend an initial approach to fecal incontinence management in your own practice. There's lots of terminology thrown around and many times used interchangeably, so let's start with some definitions. Anal incontinence is the involuntary loss of solid or liquid stool or an involuntary loss of flatus. Fecal incontinence refers only to involuntary loss of stool, whether it be liquid or solid. And then we have these other terms, accidental bowel leakage and stool leakage. These terms are interchangeable with the term fecal incontinence, and our research shows that the majority of patients with fecal incontinence prefer simple, non-judgmental terms such as these. We can further categorize fecal incontinence symptoms based on urgency and awareness. Fecal urgency is an inability to defer defecation for greater than 15 minutes, which seems like a long time, but most people can defer the urge to have a formed bowel movement for 15 minutes. Urge fecal incontinence is when the awareness of the desire to defecate is present, but incontinence occurs despite efforts to retain stool. And passive incontinence is a lack of awareness of the need to defecate before the incontinence episode occurs. Studies possibly underestimate the prevalence of fecal incontinence, since many patients are just reluctant to report it. Estimates of the prevalence of fecal incontinence vary depending on what definition you're using and the population being studied. In a systemic review of 38 studies with sample sizes ranging from 300 to 20,000 individuals, the median prevalence of fecal incontinence was overall 7.7%. But when we look at population-based studies of community-dwelling women, we have an estimate for the prevalence of monthly fecal incontinence at 9% and less frequent symptoms at 19%. And from an observational study of women aged 82 to 87 years, which included over 5,000 women, the prevalence of fecal incontinence was higher at 14%. Even in patients with mild or infrequent symptoms, fecal incontinence negatively affects quality of life. It's associated with feelings of frustration, increased risks of depression, shame, guilt, and social isolation. Patients report a substantial effect of fecal incontinence on social activities, emotional health, travel, and physical recreation. Despite the severe negative impact on quality of life, less than 1/3 of women with fecal incontinence discuss symptoms with a healthcare provider. Seeking care is more common in patients with more severe symptoms that are present for a longer duration. What's interesting is that we found that even amongst patients with concurrent urinary incontinence that are seeking urogynecologic care, their fecal incontinence symptoms are much less likely to be verbally disclosed. And maybe what's even more disturbing is that many patients with fecal incontinence who've attempted to seek care have reported that their healthcare provider dismissed their concerns or didn't offer treatment solutions. Overall, less than 3% of patients with self-reported fecal incontinence actually received a documented clinical diagnosis. So now you guys are probably wondering, how can I diagnose fecal incontinence and treat it? Which is great, we're all on the same page. To set you up for success, we can briefly talk about anatomy and physiology. So starting outside at the anal verge is the distal end of the anal canal. It's a transition point between the skin around the anus and the anal canal. The skin around the anal verge is called the perianal skin, and it contains sweat glands and hair follicles. As you're transitioning inside of the anal canal, you lose that keratinized skin and it becomes hairless. Now moving on to musculature, there's an extension of the external anal sphincter called the conjoined longitudinal muscle. It spreads out over the dermis of the perianal skin. These muscle fibers surround the anal verge and give a typical appearance of creases seen externally around the anus. And as we move internally, we get to the anal canal. The anal canal is the most distal portion of the digestive tract and is approximately 2 to 3 inches long. The proximal portion of the canal is connected to the rectum, and the distal portion terminates at the anal verge. The anal canal is surrounded by the internal and external anal sphincter muscles, as well as portions of the pelvic floor musculature. Anal continence is complex and requires coordination from a few muscles, which include the internal anal sphincter, the external anal sphincter, and the puborectalis. First, we have the internal anal sphincter, which is the final extension of the rectal circular smooth muscle. It surrounds the anal canal and is under autonomic control through the pelvic splanchnic nerves. It contributes 80% of resting anal canal tone. The external anal sphincter is a striated muscle that sits around the anal canal and partially overlaps the internal anal sphincter. It's innervated by the inferior hemorrhoidal branch of the pudendal nerve and is under voluntary control. The external anal sphincter contributes 10 to 15% of resting tone, but it's really responsible for anal squeeze pressure. It's helpful to be able to contract the external anal sphincter for conditions of threatened incontinence. But realistically, max contraction hold is 30 to 60 seconds, and most folks time out at 5 to 15 seconds. And I do want to mention that the rest of the resting tone comes from the hemorrhoidal plexus. And finally, we have the pelvic floor musculature, or the levator ani. The puborectalis is part of the levator ani. It's a striated muscle under voluntary control. The puborectalis forms a sling around the rectum to essentially suspend the rectum anteriorly towards the pubis. There's a baseline contraction of the muscle from baseline muscle tone, which helps form an anorectal angle of 90 degrees, which some think contributes to continence in some form. Relaxation of the puborectalis allows the anorectal angle to open up, or in other words, allows the rectum to straighten out. And for the purposes of continence, as the levator ani muscles contract, they squeeze the structures within the levator hiatus by pulling them towards the pubic symphysis, which generates pressure in these organs. As depicted in the bottom picture, studies have found that in asymptomatic women, the anorectal angle is 90 to 100 degrees at rest, 70 degrees during squeeze, and 120 degrees during defecation, which really allows you to appreciate how the relaxation of these muscles allows for straightening of the anorectal angle. Now, putting this all together, I don't have a pointer, but I think it's easy to follow if I just go through it. When stool or gas moves into the rectum distends, and sensory nerve endings are stimulated via the pelvic nerve afferents. These transmit impulses to the spinal cord and cortex. The cortex sends motor impulses to the descending colon, sigmoid, and rectum through the efferent nerves of the pelvic nerve. These impulses cause contraction of the sigmoid and rectum and relaxation of the internal anal sphincter. At this point, the external anal sphincter is still contracted. The relaxation of the internal anal sphincter allows filling of the proximal anal canal for essentially sampling whatever is in the rectum by the nerve endings of the anal canal. They can differentiate liquid, solid, and gas. This reflex gives the central nervous system a chance to stop or go ahead with flatulence or defecation if the setting is appropriate. This reflex is called the rectoanal inhibitory reflex, or RARE. If it's the appropriate place to evacuate your bowels, then the puborectalis and the external anal sphincter voluntarily relax, and the abdominal musculature is further recruited to increase intra-abdominal pressure and allow for defecation to occur. So now we can move on to pathogenesis. Fecal incontinence can result from a disturbance at any of these levels, either due to the type and transit rate of stool, a dysfunction in the neurologic system, rectal issues with decreased sensation or decreased compliance, or due to dysfunction of the musculature of the pelvic floor and anal sphincter complex. Many times women have more than one area of deficit, which leads to fecal incontinence. For the purposes of this lecture, I'll focus on stool consistency and the pelvic floor and sphincter mechanism. Stool consistency plays a huge role in continence. In general, well-formed soft stool is easier to sense and control than either loose or hard stools. Urge-associated fecal incontinence is more common in the setting of loose stools because stools that are too loose can result in an inability to control stool boluses delivered to the anal rectum. Stools that are too hard may result in overflow incontinence as well as incomplete evacuation. Hard stools result in fecal incontinence, which produces a constant inhibition of the internal anal sphincter tone, and that can allow leakage of liquid stool around the impaction. A number of factors can contribute to the development of fecal impaction, which include impaired cognition, immobility, rectal hyposensitivity, or an inadequate intake of fluids. Another pathology leading to fecal incontinence is anal sphincter weakness. This may be due to traumatic or atraumatic causes. Decreased anal sphincter pressures can result from anal trauma, like that related to childbirth, anal rectal surgery, fistula repair, hemorrhoidectomy, or treatment for malignancy like low anterior resection. Anal sphincter laceration or trauma to the pudendal nerve during vaginal delivery can also result in fecal incontinence. The overall risk of obstetric anal sphincter injury from a meta-analysis of 8 observational studies that included over 100,000 women was actually 6.3, with 5.7% in the first pregnancy. However, all anal sphincter tears don't result in fecal incontinence. A systemic review that included over 100 patients reported that only 29% of women with actual defects reported fecal incontinence symptoms. Risk factors for fecal incontinence after vaginal delivery, even without an anal sphincter injury, include the use of forceps, a high birth weight infant, a long second stage of labor, and OP presentation of the fetus. Even in the absence of an obstetric anal sphincter injury, labor and delivery can cause ischemia, stretching, and compression of neuromuscular tissues that contribute to incontinence. Women may not have symptoms for years after sustaining these injuries because they have compensatory mechanisms that allow for maintained continence. Atraumatic causes of anal sphincter weakness include things that impact neuromuscular health, like diabetes, spinal cord injury, stroke, multiple sclerosis, and increasing age. Interestingly, when we look at data from the Nurses' Health Study, the current or past use of hormone replacement therapy in postmenopausal women was associated with a modestly increased risk of fecal incontinence. Compared with women who never used hormone therapy, a multivariate hazard ratio for fecal incontinence was 1.26 at a 95% confidence interval for past users and 1.32 for current users. The risk of fecal incontinence increased with longer duration of hormone replacement use and decreased with time since discontinuation. It's hard to explain the mechanism behind this, but it's just something to consider as gynecologists taking care of postmenopausal patients. So now with all this background in mind, we can move on to evaluation and treatment. ACOG recommends proactive screening for fecal incontinence among women with risk factors, which include these: older age, loose or liquid stool consistency, fecal urgency, urinary incontinence, diabetes, and hormone therapy use. Qualitative research in women with fecal incontinence confirms that patients prefer that healthcare professionals ask them about their symptoms. When patients with fecal incontinence were asked what's important to them about their symptoms and what they're asked about, they reported that stool consistency, frequency of loss, and the amount of loss were critical to evaluation. A detailed history should include bowel habits, frequency, consistency, triggers, and relevant underlying medical conditions like disorders of the bowel, diabetes, neurologic disorders, prior cholecystectomy, prior anorectal trauma, surgery, obstetric history, and radiation therapy. Red flag symptoms like bright red blood per rectum or black tarry stools should prompt evaluation for malignancy regardless of patient age. Healthcare professionals should confirm that colorectal cancer screening is current in all patients age 45 or older. And finally, while the use of patient-reported measures isn't necessary, these instruments can help further categorize fecal incontinence symptoms. These are just a few of the many patient-reported measures that are available for fecal incontinence screening. These measures can further categorize fecal incontinence symptom severity, effects on quality of life, potential triggers, modifying factors, and stool consistency. Because fecal incontinence is difficult to qualify in clinic, reliance on these patient-reported outcomes can be helpful to evaluate symptoms and progress. I'll go through the Bristol Stool Form Scale and some other validated questionnaires. My recommendation would be to have the patients qualify their stool consistency and then just be aware of these other measures in case you want to refer to them to better characterize symptoms. The Bristol Stool Form Scale is a useful tool to describe and evaluate stool consistency. Types 3 and 4 represent optimal consistency for defecation. Using standardized scales improves communication between providers and patients, just because personal definitions of stool consistency can vary. Overall, it's a useful guide to describe intestinal transit time and is a widely used research tool to evaluate the effectiveness of treatments in improving stool consistency. The Fecal Incontinence Severity Index helps define severity of fecal incontinence based on type of incontinence and frequency. Patients indicate how often they have leakage of gas, mucus, solid, and liquid stool. The final result is the sum, which can be anywhere from 0 to 61, where the higher score represents a higher perceived severity of fecal incontinence. From previous studies, this score above 30 predicts a detrimental effect on quality of life. Another instrument is the Fecal Incontinence Quality of Life Questionnaire. This was developed specifically to evaluate health-related quality of life specific to fecal incontinence. This is a reliable and valid scale with 29 items that form 4 subscales. These subscales are lifestyle, coping behavior, depression, self-perception, and embarrassment. Patients are asked a series of questions with scores ranging from 1 to 5, with 1 indicating a lower functional quality of life. Subscale scores are the mean response to all items in the subscale. These are the remaining components of that questionnaire. This questionnaire is important because quality of life is difficult to define, but generally we can agree that it encompasses physical, psychological, and social well-being, and it should be measured from a patient's perspective. Now moving on to the St. Mark's-Vasey score. This score evaluates symptoms over the last month, where no represents no episodes in the past 4 weeks, rarely represents 1 episode in the past 4 weeks, sometimes represents greater than 1 episode in the past 4 weeks, but less than 1 a week, and weekly and daily are self-explanatory. The maximum score is 24, which represents a person who is completely incontinent. And finally, the CRADI-8 is an 8-question subscale of the Pelvic Floor Distress Inventory 20. Patients answer yes or no to these questionnaire items, and they're scored 0 for no items, and if they answer yes, they're scored on a Likert scale from 1 to 4, 1 being not at all and 4 being quite a bit. The mean value of all these questions is then multiplied by 25 to receive a score from 0 to 100. The higher the score, the greater perceived impact that the pelvic floor dysfunction has on their quality of life. Again, use of these reported measures isn't necessary, but these instruments are just helpful to keep in mind if you need to further characterize symptoms. I think using the Bristol Stool Scale to have an idea of stool consistency is the most recommended thing I would say in your practice, and then keep the rest of these instruments in mind if you do want to better characterize symptoms. Now that we have our history, we can move on to physical exam. So just start with an external exam and inspect the perianal skin. Assess the skin for any changes, lesions, masses, external openings or fistula, hemorrhoids, or prolapse. The image in the top right is depicting a posterior anal fissure. The images in the bottom right-hand corner and right middle are depicting external hemorrhoids. Look for any evidence of disruption of the external anal sphincter, which is obvious in the picture to the left, showing a loss of the concentric anal creases anteriorly. This is called a dovetail sign. Patients may also exhibit incontinence-associated dermatitis with appearance of inflamed or even eroded weepy skin, as shown in the bottom middle image. The next part of your exam should include assessment for the anal wink or anal reflex. In a position where you can view the perineum and anal verge, the examiner can use a cotton swab as a tactile stimulus to the perineal and perianal skin to cause a contraction of the anal sphincter muscles. This stimulus is detected by nociceptors in the perianal skin and incorporated by the pudendal nerve spinal segments S2 to S4. Pelvic floor strength can be assessed by inserting a single digit into the vagina and assessing levator ani muscles via palpation. Muscle tone can be documented as hypotonic, normal, or hypertonic. Any tenderness to palpation should also be documented. Pelvic floor strength can be documented using a Brink score as shown on the right. This is evaluated by inserting a single digit 4 to 6 centimeters into the vaginal canal and instructing the patient to contract the pelvic floor as if attempting to pull the examiner's finger inward. The Brink scale incorporates a combination of 4-point scales in 3 categories: squeeze pressure, duration of squeeze, and vertical displacement of the examiner's finger. The overall score range is 0 to 12. A score of 12 represents maximum pelvic floor strength, which represents a strong circumferential squeeze that can pull the examiner's finger inward and last greater than 3 seconds. Inter-rater reliability for the Brink score is high. And finally, we complete the focused physical exam with a digital rectal exam. Now, these images are of an exam being performed in the left lateral decubitus position. During digital rectal exam, the patient should first be instructed to perform the Valsalva maneuver or bear down during insertion of the examiner's finger, because this allows the external anal sphincter and pelvic floor to relax. Once your finger is inserted, first check the anal sphincter resting tone, and then ask the patient to squeeze to assess the anal sphincter squeeze tone. Then insert the finger deeper into a position just proximal to the puborectalis. This feels like a ridge against the posterior rectum. Ask the patient to squeeze, and the muscle will tighten and push towards the rectal finger during squeeze. Last, expulsion is tested, and the patient is instructed to squeeze or Valsalva. The patient is instructed to Valsalva or bear down, which should relax the anal sphincter and pelvic floor muscles so that you can feel decreased tone in these muscles and the examiner's finger is pushed out. After a thorough H&P, if there aren't obvious abnormal findings, patients can be started on treatment. But providers always want to know, is imaging necessary, or when is imaging necessary? Imaging is not necessary. Ancillary testing or even subspecialist referral isn't necessary to initiate treatment in straightforward fecal incontinence without red flag symptoms or obvious abnormalities on exam. However, the types of tests we consider in more complicated cases or in those that don't respond to initial treatment are endoanal ultrasound imaging, defecography, dynamic MRI, and anorectal manometry. For the purposes of this audience, I'll focus on endoanal ultrasound, which is not pictured here. I just thought it would be fun to show a dynamic MRI. Endoanal ultrasonography identifies defects in the internal and external anal sphincter muscles. It's most useful in situations in which a patient has experienced a pelvic trauma and we're considering surgical repair of the anal sphincter. Endoanal ultrasound imaging allows lesions to be characterized as full or partial thickness and by degrees of disruption. Inter-rater and intra-rater reliability remains an issue, but the test itself is relatively low cost and overall accessible, which makes it a reasonable diagnostic tool to consider. Some machines have the ability to reconstruct 3D images, and translabial or transperineal approaches can be used to reduce patient discomfort. Echocardiography and dynamic MRI are specialized tests that can be considered to identify rectocele, enterocele, rectal prolapse, and visualize pelvic floor muscle activity during defecation. Overall, these tests may be helpful when the physical exam doesn't correlate with patient-reported symptoms. And finally, anorectal manometry assesses anal sphincter function, sensory dysfunction, and tests the recto-anal inhibitory reflex or sampling reflex that we talked about. But these data don't always correlate with symptoms, so we don't recommend routine use of this test. So let's run through some endoanal images and get everyone a little more familiarized. These images are taken with a transanal ultrasound probe that look very similar to a transvaginal probe. Let me see if I can try to get the mouse over. So the transanal ultrasound probe is in the center here. This is the subepithelial or submucosal area that's hyperechoic. Then the internal anal sphincter is hypoechoic. And then there's this mixed echogenic ring of the external anal sphincter. This is a normal image with both sphincters intact, as is this image with the probe, the submucosal ring, the hypoechoic ring of the internal anal sphincter, and the mixed echogenic ring of the external anal sphincter. In this image, there is some disruption. So here's the probe. The internal anal sphincter, you can see that there is some disruption in the hypoechoic areas from about 10 to 12 o'clock. And there is some defects in the external anal sphincter, which appears to be partial thickness throughout this area. In this image, the internal anal sphincter appears intact all the way around, and the external anal sphincter is completely disrupted from about 9 o'clock to 1 o'clock. And then in these images, image A in the top panel is of a 34-year-old that had an NSVD, and she was asymptomatic. She has a normal finding of an intact internal anal sphincter and external anal sphincter. Image B is a 34-year-old after a vacuum-assisted vaginal delivery. She's also asymptomatic. In this picture, the internal anal sphincter or hypoechoic ring is intact, but there is a partial thickness defect in the external anal sphincter in the area that's identified from 12 to 2 o'clock. Image C is a 29-year-old after a vacuum-assisted vaginal delivery over a 3A laceration. She's asymptomatic. Her internal anal sphincter is intact, but there is a full thickness hypoechoic area in the external anal sphincter from 9 to 2 o'clock as marked. And image D is a 30-year-old after an NSVD over a cult sphincter injury who's symptomatic with fecal incontinence. There is a hypoechoic area, full thickness at the external anal sphincter from 10 to 2 o'clock that's marked, and discontinuity of the hypoechogenic ring of the internal anal sphincter from 9 to 11 o'clock, which indicates internal anal and external anal sphincter injuries. And then the bottom panel I'll run through quickly, but image A is normal with intact internal and external anal sphincters. Image B has an internal anal sphincter that's intact, but an external anal sphincter injury at about 1 o'clock. And image C is an intact anal sphincter, internal anal sphincter, but an external anal sphincter injury around 10 to 11 o'clock as marked. So moving on to treatment, at one point or another, all of these options were used for fecal incontinence treatment. But now the mainstay of treatment is conservative management with optimizing stool consistency, which allows for improved control. If conservative management isn't adequately relieving symptoms, then the most effective treatments are through sacroneuromodulation or, as a final resort, colonic diversion. We'll touch on why these other grayed out methods aren't as effective, but let's chat about these methods first. So when starting with conservative management, these recommendations can all be initiated simultaneously. First, figure out the triggers and avoid them. Avoiding caffeine or incompletely digested sugars like fructose or lactose can improve symptoms. If patients aren't sure what's triggering them, then they should be advised to keep a food and symptom diary to identify factors that cause loose stools and incontinence. Next, ensure that women are aware of their daily fiber recommendations. The recommended daily fiber intake is 25 grams for women under 50 years and 21 grams for women 50 or older. Patients can check nutrition labels to ascertain the fiber content of the foods they consume. Whole grain foods, fresh fruit, vegetables, legumes, and nuts all contain both soluble and insoluble fibers. One serving of a high fiber cereal contains 10 to 12 grams of fiber, and a serving of beans or legumes contains 8 to 12 grams. If patients are having a difficult time with fiber intake, they can supplement fiber. A randomized control trial of dietary fiber supplementation for fecal incontinence in patient with loose stools found that 16 grams of psyllium daily decreased the frequency of fecal incontinence episodes in both intent to treat and per protocol analysis. For reference, 1 rounded teaspoon of Metamucil contains 2.5 grams of psyllium, so a patient would have to consume a little over 6 rounded teaspoons to get their daily intake. Gradual increases in fiber are recommended to avoid bloating and flatulence. And as always, referral to dietitian or clinical nutrition can be helpful in evaluating dietary modifications to improve their stool consistency. A number of antidiarrheal medications have been used to treat fecal incontinence in patients with frequent loose stools, including loperamide or Imodium and diphenoxylate hydrochloride atropine sulfate or Lamodal. Women vary widely in the dosing and use of these agents. Some women may take these agents daily, while others just use them in public to get a little added reassurance. The Fecal Incontinence Prescription Management, or FIRM trial, showed reduced frequency of fecal incontinence episodes and improved quality of life in a randomized, double-blind, placebo-controlled crossover trial comparing loperamide with psyllium. Constipation rates were higher in the loperamide group at 29% compared to the psyllium group at 10%. When used for acute diarrhea, loperamide dosing starts at an initial dose of 4 milligrams, followed by 2 milligrams after each unformed stool to a maximum of 16 milligrams per day. Patients with fecal incontinence can start with lower doses. Start at 2 milligrams daily and increase as needed. Loperamide has several advantages compared with atropine sulfate or Lamodal, including improved efficacy, availability without a prescription, a more favorable safety profile, and less potential for dependence or abuse. Lamodal has a starting dose of 2.5 milligrams 2 to 3 times daily and can be titrated up to 5 milligrams 3 to 4 times daily. For patients who don't respond to loperamide, other antidiarrheal agents like bismuth subsalicylate or bile acid binders like cholestyramine, particularly for patients with a history of cholecystectomy or ileocholic resection, can be useful for alleviating symptoms. Pelvic floor exercises are often recommended for fecal incontinence treatment. Whether or not exercises are more effective than these other conservative measures isn't clear, but given their low risk profile, they are recommended. Biofeedback therapy is a neuromuscular training approach that includes the real-time assessment of pelvic floor muscle pressure during these pelvic floor exercises. Clinical trials evaluating the efficacy of biofeedback are conflicting, but that's partly due to a lack of standardization of these trials. More recent trials do have promising data, and increased pelvic floor strength and improved fecal incontinence symptoms have been reported. Either way, a combination of interventions of trigger avoidance, improving stool consistency, and pelvic floor physical therapy poses little risk and can improve symptoms. Devices for fecal incontinence also haven't been extensively studied, but in an observational study of a vaginal bowel control device, of 91 patients who used the device for 1 to 12 weeks, more than 75% achieved at least a 50% reduction in their frequency of incontinence episodes. The vaginal bowel control device, shown in the upper right corner, must be fitted by a trained clinician and requires ongoing self-care for use. The device is fitted in the vagina and has a balloon that's inflated to obstruct the anal canal. The balloon is deflated for defecation. Overall, the risk profile of this device is low. And anal inserts are the last thing I'll talk about in conservative management. They haven't been studied as well, and their efficacy hasn't been established. Prior iterations have been poorly tolerated, but a newer product shown in the bottom right corner is a single-use, soft, flexible anal insert made of silicone that could be better tolerated. Moving on to surgical treatments for fecal incontinence, we can start with sacral neuromodulation. Sacral nerve stimulation is considered a first-line surgical therapy for fecal incontinence in all patients with or without anal sphincter defects. Sacral neuromodulation delivers a pulsatile electrical current through an electrode placed at the S3 nerve as it exits the sacral foramen. Although its mechanism of action is not completely understood, it's thought to improve bowel incontinence by stimulating afferent somatic fibers that normalize colonic mobility and are thought to cause rectal retropulsion and possibly improve internal anal sphincter function. This device requires a test phase before permanent implantation to ensure that the therapy will be effective. Patients keep a baseline symptom diary for a minimum of 1 week and 1 to 2 weeks after placement with an electrode that receives electrical impulses. If the patient has at least a 50% reduction in fecal incontinence episodes, then a permanent neurostimulator is placed. Patients can choose rechargeable or non-rechargeable batteries, and depending on the program level or stimulation level, their batteries can last 10 to 15 years. We have data from a landmark trial that demonstrated sacral nerve stimulation safety and efficacy. This trial included 133 patients, of whom 120 underwent implantation. Fecal incontinence episodes decreased from approximately 9 to 2 in a week, with more than 80% of patients meeting a threshold for 50% reduction in their symptoms, and 40% achieved complete continence. Patients in this series were followed for 3 to 5 years, and their symptom improvement persisted. 35% underwent repeat surgery for device revision, replacement, or explant, which is consistent with rates of revision for the device overall. And to reiterate, sacral neuromodulation was initially tested in patients with an anal intact sphincter, but subsequent trials have confirmed improvement in fecal incontinence symptoms, even in patients with large anal sphincter defects. And finally, we can chat about colonic diversion. Overall, diversion is reserved for patients with intractable symptoms who've failed conservative medical management and sacral neuromodulation. Continence can be reliably achieved through diversion for patients with severe, refractory, bothersome fecal incontinence. There are several types of bowel diversions, but when we're doing a diversion for fecal incontinence, a colostomy is the most beneficial due to a decreased risk for dehydration and electrolyte abnormalities. This is particularly beneficial in our older patients. And if the distal rectum and anal rectal sphincter are removed, then there isn't the same experience of mucus leakage that patients with a rectum in place might experience. Now, moving on to those surgical options that must not be named. I just wanted to reference Harry Potter. Sphincteroplasty was once considered a mainstay therapy for fecal incontinence in patients with a prior obstetric anal sphincter injury. But its popularity has decreased with the emergence of sacral neuromodulation as a less invasive and more effective option, even effective in patients with a significant sphincter defect. There are exceptions, specifically for women in the acute postpartum period. When a patient experiences fecal incontinence or fecal urgency in the acute postpartum period, we have to evaluate them for perineal breakdown, anal sphincter separation, or fistula, and treat them surgically. So sphincteroplasty really should be performed primarily for women who are postpartum and their symptoms are immediately following a trauma. Although sphincteroplasty can improve symptoms in the short term, it rarely provides complete continence restoration. Overall success rates of sphincteroplasty are 50% at 5 years and 0 to 10% at 10 years. Surgical complications include wound dehiscence, nerve damage, and infection. Complications occur approximately 25 to 50% of the time, with patients aged 50 or older having worse outcomes. Replacement with artificial bowel sphincter implantation is associated with high complication rates and risk of explantation or revision. For example, gracilloplasty has a very high morbidity, and the technique has largely been abandoned in the United States for sphincter replacement. The artificial bowel sphincter followed the same route and is no longer available in the United States. A magnetic anal sphincter seemed to have promising efficacy, but high rates of complication at 70%, and the device was taken off the market in 2017 due to industry. There's also a transobturator posterior anal sling with 69% of patients reporting improvement, but the complication rate was greater than 66%, where there was some type of complication of mostly pain or infection. And finally, moving into this last category of augmentation, anal canal bulking can be administered in an outpatient setting. Injections are placed in multiple locations around the anal cushions, and in many trials, individuals required repeat injections because their effects diminished over time. Little is known about long-term results, but we do think this could be considered a short-term option in patients who aren't surgical candidates. And finally, radiofrequency ablation. This is a procedure that involves delivering temperature-controlled radiofrequency energy to the anorectal junction. It creates thermal lesions under the mucosa. It's not recommended for treatment since we don't have any data on efficacy. And finally, I just wanted to briefly touch on my fellow thesis project. Behavior modification and pelvic floor muscle exercises are first-line therapies for fecal incontinence, but they require significant patient motivation. Digital therapeutics are emerging to support patients in this work, and they're well described for urinary incontinence, but there's less data about digital therapeutics for fecal incontinence. One digital therapeutic pelvic health system that's been cleared by the FDA for prescription use at home consists of an intravaginal motion-based wand that pairs with an app on the user's smartphone. Users are instructed to use the system twice daily for 2.5 minutes, and remote health coaching is available for all users. While we know that there's benefit from pelvic floor physical therapy and pelvic floor exercises from recent studies, we don't know the optimal timeframe for management. Our study will primarily assess whether 8 weeks of use of this pelvic health system is non-inferior to 16 weeks of use. We're evaluating this treatment in women with fecal incontinence. Participants are randomized and instructed to complete pelvic floor muscle training using the device for 8 or 16 weeks, and surveys are completed at 0, 16, and 24 weeks. The total number of participants needed, including a 20% attrition, is 38. And at this point, we've completed our recruitment and are about 3/4 of the way through our primary endpoint. So you'll hear more about this at Department Research Day. And with that, I'll conclude the following. Anal continence is complex, and it requires coordination between the musculature of the pelvic floor, anal sphincter complex, the type and transit rate of stool, and a normally functioning nervous system. Despite the severe negative impact on quality of life and a prevalence between 7 to 19%, less than 1/3 of women with fecal incontinence discuss their symptoms with a healthcare provider. Healthcare providers should lead the discussion about fecal incontinence with their patients and use simple, non-judgmental terms that patients prefer, like accidental bowel leakage or stool leakage. While not required, the Bristol Stool Form Scale and other patient-reported measures can aid in further characterizing symptoms. Imaging and other ancillary testing is not necessary to initiate treatment for fecal incontinence. First-line management includes dietary changes, fiber supplements, and medications to optimize stool consistency. Pelvic floor therapy should be considered when feasible. Most patients will improve with this conservative management. As OBGYNs and subspecialists, we see patients with risk factors for fecal incontinence regularly, and at the very least, we should be motivated to diagnose them and get them the proper care, since it severely impacts quality of life and is underreported and underdiagnosed. These are my references. Thank you all for your attention. I'm happy to take any questions or comments. Actually. Okay. I don't know if I can get this. The mouse is tricky to get onto the screen. And I want to move that talking bubble. It's almost there. Okay. So there's magnets that loosely hold together, and you implant them circumferentially around the anal sphincter. And they're always closed, but a bowel movement generates enough pressure to separate them.
Great talk. I have a quick question. If sphincteroplasty after in the postpartum setting is the only time you ever use it, and then you had a bunch of endoanal ultrasounds of people who were asymptomatic but had significant sphincter injuries, how does the world figure out who really needs that? And is there opportunity to find more people where you could intervene early to have less trouble later as women age?
Yeah, that's a great question. I would say specifically in the postpartum period, if someone has a wound breakdown, the way we manage it depends on time from breakdown, time from delivery and repair. Typically we try to repair these within a week and a half of breakdown from delivery. Anything more than that, the tissue quality is just different because it's all healing tissue. And so we wait at that point. Many times patients, as you found from that statistic, are not symptomatic from anal sphincter defects, and sometimes have occult anal sphincter defects. And we wouldn't recommend treating those patients that are asymptomatic. I don't know if that answers your question really. I think it's up in the air.
Very nice job, Dr. Patel. I wanted to ask you about the questionnaires that are used. So we know that patients get kind of over questionnared in clinic, and in your discussion around sacral neuromodulation, you mentioned patients tracking symptoms for the week before and 2 weeks after initial implantation of the lead. And I'm wondering, in your work, have you found that there's a specific questionnaire that we should be using or adopting that tracks symptoms, severity, or bother going forward, rather than just patient subjective symptoms? Any we should be repeating as a measure of improvement for symptom bother?
I had that exact question for Dr. Jones, who was part of the GI department here and did a lot of work with fecal incontinence patients. And I think that I agree that patients are over questionnared, and I would only really recommend using these questionnaires if you can't figure out what's going on through questioning patients, or for research purposes. I feel that questionnaires are really mostly for research purposes.
All right, the one thing I know about. I like the shout out to HRT in your talk here. So, and sometimes I think we forget about that there are differences in some of the major studies that we have reporting about postmenopausal outcomes and things. Thinking about the design of the nurses' health study, what do you think might contribute to the difference that was seen in women with HRT reporting more incontinence?
I would say that you're probably an expert on that compared to me.
Do you remember the difference? Like when we think about the Women's Health Initiative versus like the nurses' health study?
No, you can
Oh.
feel free to. So they did this. I actually think I might have a. So this. I was in elementary school, though. You said. So they actually did this very clean look at the nurses' health study and compared. I can't remember the comparison groups right now, but overall, but they compared women who never used hormone therapy and women postmenopausal that did use hormone therapy. And it wasn't, there was a multivariate calculations done for, stool quality, stool consistency as well. And interestingly, they also found increases of fecal incontinence in people that were using combined estrogen progestin compared to estrogen alone. But no, I'd be happy to hear more.
Yeah, I mean, so the Nurses Health Study is an observational cohort, right? So they just put together, like recruited all of these nurses in like a bunch of different states and they just followed them over time. So there's no randomization of these people to like any treatment. They're just like seeing what happens to them. And so you could come up with a feasible hypothesis that the women who get HRT are going to a gynecologist and may get their diagnosis of fecal incontinence more, or be more likely to get a diagnosis of fecal incontinence, though we know from your other presented data that that incontinence diagnoses are low. So that's
Sure.
my theory.
Thank you. I appreciate it.
This is an easier one. Do you have a favorite fiber supplement that you tell women? Like I've heard some like Metamucil's good and other people hate Metamucil. So what do you usually tell patients?
I'll usually tell people to start with Metamucil that is only psyllium. And I tell them to make sure that the only product is psyllium. And then if that's not controlling their symptoms, I'll immediately tell them to add on a tab of loperamide.
Thanks, Ushma, for that really good talk about the most intelligent muscle in the human body. As one of the urogynecologists joked once with me and said that it's the only muscle that knows you are alone in the car. To follow the question that Dr. Heisler asked, when there are so many grading systems for anything, questionnaires, grading, and I talk from personal experience with their own endometriosis as well as uterine anomaly systems, it means that none of them work. They're all, there's a problem with everything, right? That's why. So do you know if there is any further investigation being done to figure out which is the best thing to do in terms of, because ultimately everything doesn't work if the diagnosis is not good, right? So, as you pointed out, doing a ultrasound is only helpful for those who have actually had trauma, and not everybody with fecal incontinence has had trauma. So aging is one point we just talked about as well. So from that perspective, diagnosis is the most crucial, and if you don't have a good diagnostic tool, then you're not going to be able to treat very appropriately.
I guess for, if you're just asking about the diagnosis of fecal incontinence, subjective through patient report. And so if they're reporting they have stool leakage, then they have stool leakage. And if they're bothered and want to treat it, then we should treat it. Of course, go through other things like red flags, history, things that kind of make you suspicious that it's kind of something that you should refer to either GI or urogynecology or colorectal. But outside of that, most patients will improve with conservative management and improving their stool consistency. Thank you, guys.